is Guardian Radio, your station for up-to-the-minute news and intelligent, interactive, and engaging conversations. 96.9 FM. The views and opinions of the hosts and guests are their own and do not necessarily reflect the views of the management and staff of Guardian Radio.
With early detection comes early prevention.
Put lead in your pencil, make you feel like a champion.
Rise up again, let nothing keep you down. To live your best, hear the urologist speak. Oh yeah.
Think you're losing grip of your manhood, don't give up on hope.
Don't be ashamed, it's time to take control. Get some help from the urologist.
You will find
He'll help you solve your problems
on 96.9, yeah.
I telling you, with early detection
Comes early prevention.
put lead in your pencil, make you feel like a champion.
Good evening, Bahamas. This is Dr. Greggory Pinto, Bahamian urologist. I'm joined with my co-host, Bahamian general surgeon and oncologist, Dr. Wesley Francis. We have a special guest this evening. We have general surgeon and vascular surgeon, Dr. Charles Lucas. Good evening, Dr. Francis. Good evening, Dr. Lucas.
Good evening, Bahamas.
Good evening.
So I want to start by saying this is International Men's Day. Happy International Men's Day to all of us and to the men out there. We have a crisis, and I always try to draw attention to that crisis that we are seeing unfolding in our country in so many negative ways, and so does Dr. Francis. We've been speaking a lot about the social ills in the last few weeks. We're going to talk more about the physical ills. So we're going to get into vascular surgery, but before we start that, also need to mention that today is not just International Men's Day, but we also have the month of November is Movember, where we pay particular attention to men's health by, in solidarity, not shaving and trying to grow out our mustache. That's where we go and say Movember instead of November. It's also Diabetic Health Awareness Month as well. So we're going to tie in all the vascular problems with diabetic feet, etc. They usually go hand in hand in our country. But I'm going to start this weekly show with something what I want to start every week, and that's trying to have some positivity and saying some positive words, particularly for the men out there. So I'm going to say a few words that I hope are inspirational and food for thought. So let me start by saying life is 100% better when nobody knows anything about you. So always quietly be successful. You shouldn't take advice from people who are not where you want to be in life. So always associate yourself with positive and uplifting people. Everyone will show you who they are, just give them time. So a person's true nature and colors will always eventually appear. You need to be smart enough to create your own opportunities. Don't wait for them to come to you. In our society, we blame the government for everything. Why isn't the government creating this opportunity for us? Why isn't the government giving us this job? Why don't we create for ourselves? Why don't we be self-reliant and do everything that we can within our own power to make our own lives better and make the lives of our family better? And lastly, the secret of happiness is freedom, and the secret of freedom is courage. So welcome again, Dr. Charles Lucas. Tell us a little bit about yourself. Tell us, let's not make assumptions, what is a vascular surgeon, and in what aspect of vascular surgery do you want to discuss today?
Thank you for having me, and thank you for those positive words. I'm originally from Barbados, where I met my beautiful wife, Adrienne Gomez Lucas. She's also an anesthesiologist, and we both moved back to the Bahamas, and I've really loved the last 10 years being in the Bahamas and growing my practice and being able to take care of the Bahamian population. I have a son who's 6, Anderson, and daughter, Cheryl Marie. She's 8 years. They're my heart, and I hope they're listening in, but really they should be doing their homework.
Okay, so we're going to get to all the basics, and I'm sure we're going to have to make this a two-part show because vascular surgery is such an all-encompassing topic. In fact, I have the greatest respect for you, Dr. Lucas, because I had to do 6 months of vascular surgery. When I had to do general surgery before I did urology, and that was the worst living hell on earth.
He did 2 years of general surgery, maybe, and that was it, right?
Yeah, well,
So,
6 months of that was vascular surgery.
yeah.
And I knew I didn't want to be a general surgeon. I definitely knew I didn't want to be a vascular surgeon because we would do 14-hour bypass surgeries, and then it would fail, and then we would try another 15 hours, and then we'd end up with amputation.
I thought we were going to be positive. Today.
Yeah, okay.
We were gonna be positive.
But no, you touched on a great point. One of the things that drew me to vascular surgery was these complications we have with poor circulation and diabetic feet. And from a personal point of view, my paternal and maternal grandfathers both unfortunately passed from complications of diabetic foot and poor circulation. And so for me, that was what catapulted me into vascular surgery. And where others may see no hope, I see hope. And
Yeah.
I hope to
that's
champion
true.
it.
Yeah.
And I think I love this podcast radio show because you're trying to encourage Bahamian men and women, and you're trying to get them to get medical attention early. And for vascular surgery, that's the key.
Yes.
Far too often we wait too late, and it becomes a self-fulfilling prophecy. You know, you come to the doctor at the end of the road when there's not much that can be done. But what we want to inspire the general public to do is take control of your health and your health journey from early. And that means seeing your primary care physician, seeing your surgeon very early in the game where we can do the most good.
Yeah, so when we talk about all the vascular issues, we're obviously going to divide it into arterial issues and venous issues. But the number one killer of mankind worldwide, the Bahamas included, of course, is going to be a heart attack or a stroke. So we're trying to, with lifestyle changes, behavioral modifications, dietary advice, medications if necessary, we're going to try to get you to live longer and live better. And this show promotes preventative medicine. We're trying to be proactive, not reactionary. So we want to prevent you from not only getting a diabetic foot, but getting diabetes. So knowledge is key, and the wealth of the nation is the health of the nation. So we're trying to impart as much information. So we're trying to draw attention to symptoms that persons just don't understand. So when we talk about peripheral artery disease, it's essentially, in layman's terms, almost like a heart attack of the lower limbs, where there's a lack of blood supply, perfusion, leads to ischemia, leads to tissue death. So let's talk about something that we want persons to look out for in the early stages of peripheral artery disease, and that's intermittent claudication. What is intermittent claudication, and what should persons be looking out for when they have intermittent claudication?
Wow, that's an excellent question. Intermittent claudication is a medical term. All it means is you walk a certain distance, let's say a block, and you sort of have pain. Maybe it's in the calf, maybe it's in the thighs, maybe it's in the buttocks. But you have this pain, you have to rest. You take a little 5 minutes, and then you're able to walk again, but then the pain returns. So is that reproducible pain that you get with walking? It comes in many different flavors. That's the classic one. But especially with our diabetic population, our end-stage renal disease population, patients may present with just some discomfort, some heaviness, and not know why they can't walk or do grocery or climb stairs as they used to. And it is a harbinger for, as you pointed out, severe cardiovascular disease or heart attacks elsewhere.
So it's an early warning sign that you should never ignore.
Exactly.
And usually what happens is the distance that you walk becomes shorter and shorter, and then the pain becomes more severe.
Correct.
So let's even take it to the next level, rest pain, and that's when the issue is severe. What is rest pain?
So rest pain is where the blood supply or the circulation is so poor that at rest, when you're laying down, usually at night, you start to have this pain, and it starts off quite, insignificant, but it can be quite gnawing. It can be quite severe over time. You're taking Panadol, you're taking ibuprofen, it's not really helping. So that severe pain at rest means you have a severe problem with your circulation. It's a medical emergency.
Yeah, so essentially you're not having gravity help the blood go down to the lower limbs. And classically what you'll find, and a lot of persons will just determine this just by accident, if you put your feet over the side of the bed, or you actually get up and walk around without gravity, allow the blood to go down to your lower extremities, the pain is relieved.
Correct.
So really, it's a supply-demand issue, right?
Yes.
So the supply of blood to the muscle initially, right? And that's why we get this rest pain. So as you contract the muscles with walking, the muscle has a demand, it grows a demand, and it needs more blood supply. And that's why you initially have that claudication, as it is called. And then when it gets so bad, you get basically pain, not when you are stressing your muscles or using your muscle, you get it at rest, which really means that there's a bad problem with circulation at that point.
And that could lead to what we'll say as in vascular surgery as critical limb ischemia. Your limb is at risk. Your limb is, and if you're diabetic, if you have an infection, the infection can exacerbate the problem because you're not going to have. First of all, diabetics need to. We've spoken about this many times. They need to examine their extremities because there's an issue with poor sensation. There's an issue with some poorly controlled diabetics having poor vision. Sometimes you might need to even ask your granddaughter or grandson to examine the bottom of your feet because you need to know that you might not have a little injury or a little puncture wound that's not going to heal. The infection is going to get worse because of poor blood supply. And when you have poorly controlled diabetes, you're going to be immunocompromised as well. So on top of that, the worst thing in general surgery that I've seen, and I've seen a lot of things with trauma, is the diabetic foot or critical limb ischemia.
But people like Dr. Lucas, Dr. Farquharson, they love that stuff, right? And
Good results, yes.
He mentioned how when he talks about hope, right? And how when people come in with diabetic foot infections, when Dr. Lucas sees that, he sees it as an opportunity to save. When the regular general surgeon like myself sees that, we like, oh boy, this is bad. Tell us about your approach to people when they come in, because a lot of people come in, with these bad wounds on their feet, and I've seen you and Farquharson do miracles, right? Tell us about that.
So before we even get there, you touched on something I just want to pick up. We're doing actually some interesting research looking at the presentation of peripheral arterial disease or poor circulation. Mm-hmm. Unfortunately, in our population, the first sign of patients having problems in terms of peripheral arterial disease is actually a gangrenous toe, with or without infection. And that's probably the end of the road when it comes to peripheral arterial disease. So it's a big problem. We see it far too often. So in terms of our approach...
So explain to our audience what a gangrenous toe means.
It basically means a dead, usually mummified toe.
Okay.
It's black, usually, so that's a warning sign if the toes or the foot is becoming significantly darker. Sometimes, we've missed the boat and it's completely black. That means there's absolutely no blood getting to that distal extremity. And that's usually an emergency.
Right.
In terms of our approach, it's a comprehensive approach. And I usually say when it comes to diabetes and peripheral arterial disease in general, poor circulation in general, it's a multidisciplinary approach.
Right.
And the surgeon being one of the team members on that multidisciplinary team. And what that means is, I don't want to use the fancy word multidisciplinary. All it means is we get the best of the best from all the different specialties to give the best care. So you're going to talk about making sure you have a podiatrist on board, your infectious disease specialist, because you're going to culture some weird and wonderful bugs. You may have prolonged antibiotics are necessary. You can get your internal medicine doctor that's going to control their blood sugar in hospital and out of hospital. Your general surgeon and vascular surgeon will determine if more blood needs to get back down into the foot and how best to get that flow back. And
dietitian as well.
Dietitian. I got a lot of slack for this last time. The physiotherapist, shout out to our physiotherapist. Even before you come into hospital, during your hospital stay and after, they're being on board and that continuity of care. So it's a very complex problem. It's a very resource heavy. We spend a lot of resources trying to help patients and trying to get the best outcome.
Well, good evening. We have a call coming
already?
in.
Oh,
Yes.
okay, great.
Don't want anyone waiting too long. Good evening.
Godly days is back in the voice with you, doctors.
Good evening. How are you?
I'm holding, thank God. One question to you, Doc, or you docs.
Yes, please.
When it comes to the body, right? What is the tiniest and the longest blood vein? And it leads from where to where?
Well, I hope I'm answering this correctly, but and I just want to make sure we.
You're talking about what is the largest artery in the blood in the body?
No,
or
I
talking-
want to know the smallest.
the smallest.
Right.
Okay.
Well, we know that we start off with blood leaving the heart is after it's oxygenated or your lungs put oxygen in it. And then it travels through your aorta, which is the largest blood vessel. It can then supply the brain, the hands. It has to go all the way down to supply your gut, your liver, your kidneys,
I mean, the branches that go off into the capillaries.
and then
yes.
it's going to go all the way down. And then it all divides like a tree. So if you can imagine a tree looking from the trunk down into the roots, it's going to get really small. And the smallest blood vessels we call are the capillaries.
Yeah.
And
the
then
microcirculation.
that sort of conjoins with the venous circulation. The venous circulation, I hope we get a chance to talk about it. Maybe I'll come back. Is now that blood returning back to the heart to be oxygenated by the lung and then be recirculated.
And then even when we have some of the larger blood vessels, like the coronary arteries that slowly are becoming obstructed, a lot of times you're not going to have any symptoms from that, and you would do imaging or you would do angiogram, and you couldn't believe that this person didn't have a heart attack 10 times over. But you talk about collateral supply. So the body works in wonderful ways. God has made us so that
Yeah, but
if we have obstruction,
Doc?
we can make collateral
Hello?
supply.
Doc?
Yes, go ahead.
Now, when the blood drains down to the feet, right?
Yes,
And it
sir.
has to come back up to the heart and to the brain. Let me ask you something. Doesn't that blood get sort of deteriorated, or what's the word I want to use here? Unclean by going all the way down there and coming back up?
No. So arteries take blood away from the heart, supplying nutrients and oxygen, and then when you have deoxygenated blood, the veins bring it back to the heart. And that's a perfect segue for us to talk a little bit about the venous system.
He may think of it as unclean, but it's derived of its nutrient, and the major nutrient to the muscle is really oxygen, right? And so it goes from the arteries and into the capillaries. Capillaries deliver the oxygen to the muscle for it to work. The muscle extracts all of that oxygen, goes back onto the venous side, and then the veins go back to the heart and pump to the lungs, where it gets this reoxygen supply. And it's a big circulation that way. That's why we call it the circulation. So it's not, I mean, we wouldn't use the term unclean, but it's just that the oxygen is used up in the tissues all over the body.
And one thing I want to talk about before I forget, when we talk about peripheral arterial disease and poor circulation in terms of the arteries, yes, we talk about intermittent claudication, which is the pain with walking. We talked about rest pain, and then we talk about gangrene when the toes get black and dead. But what we found is, 80% of patients with peripheral arterial disease are asymptomatic. So when you think about it, there's a large population walking around with risk factors, and we know that even without symptoms, your quality of life is decreased, your mobility is decreased, but also your cardiovascular risk increased. So you have a 2 to 4-fold increased risk of having a heart attack. You have an increased risk of having a stroke. So what we're doing now is focusing on this cohort of patients, basically looking at people who have no symptoms, are walking around with peripheral arterial disease, to say, hey, mom, sir, you have an increased risk of heart attack and stroke because of this test. And also, it predicts your risk of going on to have an amputation long term. So if we can intervene, this is where we want to be. And so we've invested in mobile, what we call ankle brachial. There's a fancy word. All we do is checking the blood pressures in the arms, but also in the legs, very early in these at-risk populations. And we're seeing remarkable results by being able to pick them up early and sort of manage their problems, whether it be hypertension, diabetes, kidney problems, high cholesterol, really get in there early, and we're seeing big changes.
Yeah, so that's something that even GPs can do before they send the patients to you on referral. You look at the ankle brachial index, you're looking at the blood pressure in the lower limb, and then you're comparing with the blood pressure in the upper limb. And if it's 0.4 to 0.9 is acceptable, what value would you be concerned about and you want a referral?
Okay, so if you're a GP, if you're doing it in your office, if you're a trained nurse, the normal range is usually 0.9 to 1.2, depending on the system you're using and the calculation. What we found, especially in diabetics and patients with end-stage renal disease, the blood pressure results can be a little bit misleading.
Yes.
Because they have calcification in the arteries themselves. What that means is the arteries get really hard and can be compressed with the blood pressure cuts. So it gives a sort of false positive. It makes it seem like you're okay, but you actually have severe peripheral arterial disease. That's something that your doctor and your vascular surgeon will be able to pick up and interpret, and making sure that you have the best outcomes.
We have a text message coming in for you, Dr. Lucas. When is calcium buildup in veins? I assume they mean arteries. And how can we correct these? So that would also be a perfect question for me to say, what about calcium score? So that can stratify someone into being higher risk for obstruction of the coronary arteries. Or when do you suggest someone does a calcium score? What is a calcium score and how often should you do it?
Well, I'll leave that more to my cardiologist colleagues. We work hand in hand. But the calcium score basically is you're trying to assess the burden of this atherosclerosis, this severe or advanced plaque throughout the body, and trying to determine how at risk they are of having a heart attack or stroke in the future. And there's a lot of research going into it in terms of the values and how to interpret it. A little deep for this conversation, but what I would say is that the same process happening in the legs when we talk about peripheral arterial disease is happening, as you said, Dr. Pinto, in the coronary arteries is the blood supply to the heart, as well as into the carotids, which is the blood supply to the brain. So when we see a problem in any of these vascular beds, it indicates there's going to be a problem in the other vascular beds. And we need to refer to our neurologist, our cardiologist, get our internal medicine doctors on board because this person is high risk. That's an alarm bell for us.
So you can back me up because I'm speaking about this all the time for years and years and almost every day in my office. A person seeking help for erectile dysfunction can literally save their life exactly for what you're saying. So the smaller blood vessels are going to be obstructed many, many years. The smaller blood vessels are going to supply your male member and going to negatively impact your erections because of the poor blood supply are going to
absolutely
appear many years before it leads to stroke or heart attack. So if we can pick up someone being at risk when they're 42, we can prevent them from getting possibly a stroke or heart attack when they're 55 or they're 60. And that can actually save their life or prevent them from going down and having a debilitating hemiparesis. Where,
absolutely. And just to back you up even further, ever so often, quite often actually, in our clinics, we see men come in, they're complaining of pain in the legs, and then they whisper to me, I can't get it up, I have a little difficulty. And these arteries supplying the male member, can I say penis?
Yeah, we can say penis.
I don't know.
That's okay.
But no, seriously, they have a problem. And as you said, if we can pick this up early, we can save them a lot of grief. And even if it's a little bit too late, there are treatment options. I know you mentioned many of them before, and I hope you can reiterate it, that all is not lost.
Never.
Right?
Never.
And therefore...
well, you're talking about our mantra. You can always rise again. Like a phoenix from the ashes, you can always rise again. We got first line treatment, we got third line treatment, we got fourth line treatment.
Show. We always end up back at...
So we have another call coming in. Good evening, this is Urologist Speaks.
Good evening to all of you.
Good evening, sir.
Good evening.
Especially you, Dr. Pinto. You're doing a wonderful job.
I appreciate that. I'm inspired by Dr. Francis, who's my mentor.
Great. Well, I am happy to know that someone is inspiring you.
And God and Jesus.
Yeah.
Holy Spirit as well.
Yeah. But you seem to be doing something that the Bahamas really needs because you don't find much of this going on where people are actually showing you how to prevent from getting there. But then when you do get there, doc, you're there.
Yes, yes.
And
So
I
you want to
appreciate
prevent
that.
people from going down that road. Correct.
Yes, yes, yes. This intermittent claudication.
Claudication.
Claudication,
Yes.
right? It seems to be something that comes on very slowly. It's
Correct.
like you're
It
not-
can.
Correct.
Yes.
Sorry?
It's an early warning sign.
Right. Now, does that have anything to do with, I'm sure it does with erectile dysfunction, but what about prostate cancer that you specialize in? Is there a correlation between this small, because I know I had an uncle who had I think it was PAD, peripheral arterial disease, and, it seemed to be very painful for him, and then he ended up dying from prostate cancer.
Well,
Is
it's
there a
just that
correlation?
both of them, one of the
Age.
greater risk factors is age. So the number one risk factor for prostate cancer is advancing age, and for peripheral arterial disease, one of the greatest risk factors. So they had that link because age puts a person at greater risk. But
Okay.
there's no direct linked in terms of causation, no.
So, but it seems to be that we either die from some form of cancer or some kind of clotting somewhere going on. It's just that
It's either going to be cancer, stroke, or heart attack for
Right.
us all, yes. And unfortunately, because of our society, or gunshot.
So no matter what you do, one of them gonna get you.
Correct.
But quality of life as well. You don't have to suffer. You don't have to be in pain for a lot of these conditions. I know Dr. Pinto talks about obesity, and about 20% of cancers being associated with being overweight.
And alcohol intake.
Alcohol intake. We talk about smoking. Both smoking cessation can prevent you from getting heart attack, stroke, or significantly decrease your risk of peripheral arterial disease.
I
as
mean,
well.
once you get to a certain level of peripheral arterial disease, now we're starting with cutting off one toe, and then we go to the hind foot, and then we go to below the knee, then we go above the knee, then you're getting
but-
disarticulation of the leg.
Yeah,
We don't
we
want you
have-
to. We want to prevent that from ever happening, because that's a horrible existence where you're in and out of hospital, getting every test prodded and probed. It's an overwhelming burden financially on our public health system, on Princess Margaret Hospital as well. 'Cause you can take up a bed for 3
true.
months.
So you raise a good question there, and Lucas, I'd like to ask you, if you start on this road, is it reversible? Can you reverse it? Tell us about how do you regain that sort of function that you would have lost, or that decreased circulation? How do you do that?
Okay, great question. So, regardless of the stage that we meet you at, I think there's always some amount of hope. And what we want to do in terms of what we call revascularization or improving the blood supply, we start with lifestyle modifications. And everyone, whether they're asymptomatic or have some symptoms, whether intermittent claudication, rest pain, gangrene, will benefit. So we know that eating a heart-healthy diet is great. We know that lowering your cholesterol, and in many cases, we would like to start you on cholesterol-lowering medications. Example, Crestor, high doses to try to stabilize that plaque. There's some evidence that you can actually reverse it, even though that's debatable. We usually put you on some medications to help with clotting, as the person talked about, thrombosis. And this would be like aspirin, Plavix, and even some small doses of blood thinners to keep the circulation going. And in very severe disease, when we talk about critical limb-threatening ischemia, this is where, without intervention, you're going to lose the limb. Then we're talking about usually surgery or some intervention. Thankfully, even though our hypertension is increasing, our diabetes is increasing, technology is also increasing, our awareness is also increasing. So right now, before the only option was big open surgeries and amputations. Right now we have small, minimally invasive, so small, tiny cuts with needles and wires, and we can open up those blood vessels. The analogy I like to use is, imagine being on a highway and there's a big backup of traffic, and a big Mack truck just comes and push everything away. That's our angioplasty, that's our ballooning up to get the circulation
Or
back.
stent placement.
Correct. Yeah. And now we have not only drug-coated balloons, so we put in the medication on the balloon, so it's directly interacting with the arteries and the arterial wall. And now we have also stents, and your surgeon will determine, which is best in what circumstances. But now we have all of these tools in our armamentarium to really tackle these problems.
What I want you to also say.
We have a
another
call waiting
caller?
for one.
Oh, okay.
Yeah, good evening.
Okay.
This is Urologist Speaks. Good evening.
You, right?
Oh, yeah.
At the blood vessels, right? The small blood vessel. When the blood comes from the feet going up to the brain, ain't you could tie off the blood in some way whereby the dirty part of the blood doesn't get up to the vein and pull that grease and whatever out of the vein and put the blood back in flow?
I'll let Dr. Lucas answer that one.
One of the things I would say is, remember when we talk about the arteries bringing the blood down to the fingers and the toes for nourishment. There's a long journey, as you rightly said, and it needs to get back up through the veins. As Dr. Francis talked about, usually your cells are going to eat and drink it. So it's like taking out the oxygen out of it, taking out those nutrients that it needs to survive and live. And then that blood is returned back to the heart to go to the lungs to be reoxygenated again, to get oxygen back again, and then to continue its journey. So it's a closed loop. We don't consider it necessarily dirty or infected. We don't need, I hope I'm answering the question correctly. But we try to keep it all. In patients who have infections, there may be a problem, maybe a source of infection in like a diabetic foot. And in that case, depending on the severity of the infection, it may go into the bloodstream. In those cases, we have to debride or cut away all the infected tissue. And in worst case scenarios, sometimes the patient may have to get an amputation. We try at all costs to avoid it. It's a last resort. We're in the business of limb salvage. That means trying to keep as many limbs on as possible, keeping our Bahamian population moving and going. We know that economically it puts a huge burden on the individual to lose a limb. And for their loved ones, the society is also a big burden. We do our best with physiotherapists and prosthetics to get this person, as they were before. It is a challenge. And so at all costs, we try to avoid it.
Good evening. We have another call coming in.
Hi, good evening, Doc. I would like to know, I have a lot of pain in my legs, and I have plenty invisible, the veins are visible. Veins. Do you work on these?
Okay. Yes, we do. So what you may be experiencing is something called venous insufficiency, or you heard the term varicose veins. This is a problem with now the circulation from the legs back up to the heart. And what can happen is inside every one of us, God made us beautifully, we have these valves. So if I stand up right now, the blood wants to tend to pool down by the ankles and the feet. And that creates a bit of pressure. But these valves stop the blood from going there. Unfortunately, with our aging population, if you have a family history, if you are on your feet for long periods of time, like us surgeons.
If you're a surgeon, yeah.
Yeah, if you're in healthcare, your nurses, your policemen, your
Waitresses,
teachers,
waiters.
then over time you can get weakness in your blood vessels, particularly these veins, and they can become very prominent. They can get painful. You can have discoloration around the ankles, and unfortunately, we know it's a progressive condition, and so you can end up having ulcers. And these ulcers can be further problematic because they can bleed, they can become infected, and in rare cases, we've seen quite a few cases where it actually go under malignant transformation as they turn into cancer. So we try to keep it, treat it early, pick it up early. It's very undiagnosed. We did a recent study, and it showed that most people will come into the doctor's office for swelling, and that swelling is usually the venous disease. I thought off-air Dr. Pinto was talking about how that's usually diagnosed and with usual treatment.
Yeah, so unfortunately, I'll even speak to our younger physicians and even the public in general. Almost seems like every person who has either unilateral or bilateral, both legs having swelling, they assume that Lasix is the answer, which causes them untold harm to their quality of life because they're urinating all the time. And a lot of these cases, maybe even more than half of these cases, is not related to their heart or their decompensated congestive cardiac failure where Lasix may help, but it's actually related to venous insufficiency. So not every lower limb swelling, Lasix is the answer. So that's where this is very important, where we're trying to partake knowledge to the public that lower limb swelling may be related to what we call venous insufficiency, where the blood is pooling in your lower limbs and is not.
I want to add something. before we're thinking about it as just a cosmetic issue, is a true medical problem.
It is, yes.
We know that in the U.S., they spend well in excess of $30 billion a year trying to treat this disease. We know that even the President of the United States was recently diagnosed with this problem, and is the most powerful man in the world. He's suffering from venous disease, and our public is suffering from venous disease. We know that with the higher stages, that is the worst. When you get this darkening in the skin, this eczema, it gets itchy, you may get pain in it. These patients have a quality of life equivalent to somebody with congestive heart failure.
And it's
Imagine
also
that.
it's also important to you don't treat this yourself. You don't just go to the pharmacy and buy TED stockings, because you need to actually have your vascular surgeon determine
Absolutely.
what pressure you
Correct.
you need.
I like to say
Yes.
it's like a prescription.
Yes.
You got to get the right strength,
Yep.
right? The right duration.
It's not
that's the life.
one size fits all.
No.
So you don't
And
treat
people
it yourself.
People
You-
buy it
yeah.
online. I get everybody comes in with they want to go Google and they bought this thing online,
And it might be
invariably-
doing more harm than good. Actually.
Absolutely. And one of the things is that, in the past, people were fearful because we only had vein stripping to
Yeah,
treat this
so
problem.
that was a horrific thing. And a lot of persons will say they don't want anything done with their varicose vein because their grandmother had venous stripping and they were painful for 6-8 weeks. All of vascular surgery is now minimally invasive.
Correct.
We can ablate. Speak a little bit about the minimally invasive options you have for varicose veins,
So
where
for-
there's little to no recovery or pain.
So, thank you so much for that question.
Do surgery on mine.
You need to do surgery. So what we have now is minimally invasive surgery. So you take tiny needles and wires. We're able to go into the blood vessel that is refluxing or causing the issue, and basically ablate it or destroy it from the inside. And this invariably tends to relieve all the patient's symptoms. Obviously, close follow-up is necessary, and it's almost painless. The downtime is minimal. You go back to work the same day, right? Or after a brief rest. Every case is different. And we're seeing tremendous results. We have a new RFA machine, and
let's say, what does RFA stand for?
radiofrequency ablation.
And how does that work?
So, not to get too technical, but it's a small catheter, a small tubing. It produces this radiofrequency energy, let's call it that, and is able to almost, it destroys the blood vessel or coagulates it from the inside. Basically destroying that blood vessel so the blood no longer refluxes back in. So if that is something that is, really affecting quality of life, as most people who suffer from chronic venous insufficiency can attest to, then I would say seek a vascular surgeon's opinion. We have a lot of options for you to get a fast, almost painless experience in dealing with this significant problem.
Yeah, so the most important take-home message is that there are answers. We're always trying to prevent them from happening, but the management is minimally invasive.
Okay, doc. So where could I go to get this surgery done?
Well, we were going to wait till the end, but how can we, if someone needs your expertise, how can we find you?
Okay. So you can find me at Doctor's Hospital. Dr. Francis is looking over my shoulder. But Bahamas Surgical Associates Center, 603-1814. And we have now the Bahamas Vein Clinic, where we're dealing with these minimally invasive, using modern techniques to treat these veins. You can call me at 552-2352 or text me, and we'll be able to get you in contact.
But if you just
with our
Google
team.
it, it's Dr. Charles and Lucas, it's Lucas, and he's a general surgeon and vascular surgeon. We have another call coming in. Good evening, this is Urologist Speaks. Good evening. You can go ahead. We lost that
So
call.
one of the things I wanted to emphasize, Dr. Lucas, because you mentioned a lot of the options for vascular, for arterial disease, and you also mentioned it for venous disease. And I think the public is not really aware of how available are these new minimally invasive techniques here.
Okay.
Can you speak to that? Like,
Yeah.
is all of that stuff available in the Bahamas? that we
Absolutely,
can do it?
absolutely. Thank
Right,
you so
okay.
much. So, as we talked about, we have the RFA ablation. There's a Claravane device.
So I don't have to go to
You don't have to
Cleveland
Cuba.
Clinic,
You don't have
or I
to
don't
go
have
to
to go to Cuba,
Panama,
or I
you know,
don't have
US.
to go to Health City
No,
to get my vein ablated or to get my stent put into my vein
Absolutely
or
not.
my artery, right?
no.
Is there any
Okay.
role for
I just wanted to
for
make sure.
varicosities? Like in urology, we have varicose seals, which is basically the same physiology with varicose veins, where you have a distension of the testicular vein because of valve incompetence or malfunctioning, where we can have the option of using sclerosing agent. Is there any role for sclerosing agents in the, varicose veins?
Absolutely. So there's a full spectrum of treatment options, individualized to the patient. So, it's not a one-size-fits-all that you alluded to earlier. So sclerotherapy, especially for the spider veins and the smaller veins, what we call telangiectasia, in medical terms. But these small veins, these usually are beneficial to use the sclerotherapy. Some would combine ablation techniques with sclerotherapy. It all depends on the surgeon's preference and actually what's presenting before them. We have laser options as well and full cosmetic treatment options as well on top of that. So I would say, whether they're big or they're small, if they're giving you a problem, your vascular surgeon can help.
And as you said, many patients are asymptomatic, but how do we pick up these patients? What imaging would you recommend? Do you say someone's 45 or 50? No real particular issues. Do we do a baseline coronary angiogram? Do we do carotid Dopplers to make sure that there aren't any early plaques that can lead to stroke?
Yeah. So that's an excellent question. What we do know, and this is one of the things that I'm hoping Dr. Francis, Dr. Pinto, you can champion, we need more screening. We do know that especially most of the major guidelines recommend screening in terms of checking for peripheral arterial disease, right? As late as 55 for high-risk people, maybe as early as 45. But making sure you at least have a baseline ankle brachial index, which is what we talked about. And for diabetics, it should be done at least yearly. So it's not a one-and-done situation. We'll be checking to see the trends over time. And as I said, we're realizing that trends are more predictive than even doing a standalone test. And making sure that you go to your primary care physicians. What a lot of people don't even know, and some of our physicians aren't aware as yet, but the American Heart Association new guidelines for hypertension came out. And if your systolic blood pressure is above 130 over 80, you're hypertensive. Yeah. And that's a shocker for a lot of people, right? It means you've got to get yourself in shape, right? Because you've just gone into the bracket of patients high risk of ending up with heart failure, heart attack, stroke, amputations.
So when you talk about stroke, that's along with myocardial infarction and heart attack, one of the number one killers of Bahamians and persons throughout the world. What about screening using carotid Dopplers to try to determine who is already at risk even 15 years before that potential stroke?
Correct.
Where you can minimally invasively, endovascularly remove those plaques from those carotid arteries.
So not to get too technical again, but for the Society of Vascular Surgeons, they recommend at least one-time screening if you're a male and you ever smoked, or have a history of smoking.
At what age?
At least, before the age of 75, okay? So what we're trying to do is, in those cases, pick up those high-risk patients who are actually going to have a stroke. And what we find is that, that's for asymptomatic disease, but a lot of patients have symptomatic disease that's being misdiagnosed. So warning signs will be dizziness, blurred vision, you may have blindness in one eye, you may have drooping of the face that quickly resolves, or weakness in the upper limbs that may or may not resolve in a matter of minutes. And people may brush this off, especially our older folks, and say, hey, I had a Passover, this is something, I didn't take my sugar, but what they had is a mini stroke or TIA. And for those patients, they're at increased risk of having a major stroke, especially in the next month or so. So if you're having those symptoms, you got to see a specialist, get that ultrasound in it, see if you have plaques, see how bad it is, and get some treatment.
And I mean, one of the things that we can do is get our annual physicals. We always promote that, and making
Absolutely.
sure that you don't have hypercholesterolemia. That starts it all. We have another call coming in. Good evening. This is Urologist Speaks.
Good night.
Good night. Good night. Thank you for the call. Please go ahead.
Dr. Pinto,
Dr. Lucas and Dr. Francis.
Yes, sir. I want to know if you're not diabetic, if your sugar level is normal, but you may have high cholesterol, and your PSA could be like 35. Was that you find yourself with a dark spot on your
on your shank area of your feet, right?
Well, first of all,
Indeed.
let me just, sorry to disturb.
Hello?
You said PSA, you're talking about prostate-specific antigen blood value being 35?
Oh, I can't hardly hear you.
You said PSA. What did you mean? You meant
The
prostate-specific
PSA
antigen?
is 35.
Okay, well that's very high. Although that in itself is not diagnostic because
That's very high.
it is very high. It's always age-specific and it can be elevated for many reasons unrelated to prostate cancer. But when you have a PSA of 35, we have to urgently try to ascertain the reason for that. It might be that you're not emptying your bladder. It may be that you have severe prostatitis. It may be that you have a very big but normal prostate. But we still want to make sure that you don't have early prostate cancer, because if you do have early prostate cancer and we can pick it up and treat it, your chance of survival is 100%. If we wait until the disease is beyond the capsule, beyond the confines of the organ itself, then you're only for palliative care, and we don't want you. There are too many men dying needlessly of prostate cancer in this country. And then what you mentioned is your sugar is normal. There are far too many persons who are diabetic who will take a fasting sugar in the morning when they haven't had anything to eat, and it might be in the normal range or a little bit above normal, and they assume that their diabetes is well controlled. That's the worst thing you need to do. First of all, the basics are you need to have a diabetic diary. You need to check your sugar in the morning. You got to take it before meals. You got to take it 2 hours after your meal, and you need to see the trend, because your diabetes, the actual blood test that you need is called a HbA1c, which will determine how is your body dealing with sugar in the last 3 months, not in that one-time isolation. But a PSA of 35 of what you said is very concerning, and you need to see a urologist, sir.
Yes.
But what were you saying about? Sorry, you saying there was a black?
Hello?
Yeah, you're. Sorry, go ahead.
I can't hear you.
Oh, sorry. You were saying you had a black mark on your lower limb?
Black mark on the limb. It's on the shin bone above the ankle,
Okay.
almost midway. I
Then
wonder if that would be from poor circulation.
it could be. I'll let Dr. Lucas elaborate. But yes, don't ignore that. A lot of things that you've said, you need to see a physician.
Okay, you deal with that too, right?
The dark spot, Dr. Lucas does, or Dr. Francis as a general surgeon, but I would go to Dr. Lucas, and please see myself or one of the urologists for your PSA being 35, sir. But thank you very much for your call.
Thank you.
Yeah, so we've said a lot, but the most important thing is that we want to be proactive, and let's talk about lifestyle choices. A lot of men will hammer me and they don't like it, and they'll get in groups on the golf course and say they don't like Dr. Pinto talking about smoking cigars because that's their only bad vice. Let's talk about smoking and the link to peripheral vascular disease. They're blaming me, but let's hear it from you.
Oh, man, I'm going to get some heat for this too then. Definitely smoking is one of the biggest modifiable risk factors for developing peripheral arterial disease. What that means is it's something that you can stop today, and it's going to prevent you from or decrease significantly your risk of having peripheral arterial disease. And that can be cigarettes, cigars, or now the vaping.
Which is almost as or more dangerous than even
so we're seeing a lot of
cigarettes,
young people with cardiovascular disease from the vaping and not recognizing that these products having tobacco.
Or even secondhand smoke.
Absolutely.
Particularly for young persons or elderly persons. So stop being selfish. And I always say, when you smoke, a lot of times, all of that will permeate into your clothes, into your skin, into your hair follicles, and then you go pick up your baby or interact with your grandson or after you've smoked cigars on the golf course. So please, live longer, live better, make smart choices. We have another call coming in. Good evening, this urologist speaks.
Yes, good evening to Dr. Pinto on the panel.
Good evening, good evening.
Yeah, he's frightening, the heart doctor is frightening me, right?
Yes.
You know, I exercise a lot, and, I don't look my age, but, it catches up with everybody. But he said something very, very, very important, that's something that I had thought about. And I think he said mentioned that they take blood pressure in the arms and in the legs.
Correct.
And so as much as you remember when one time I went to see you, Dr. Pinto, and my blood pressure was elevated, and something I was telling you recommend the blood pressure pill, and I was like, I exercise, and you tell me I can exercise all I want, wait. But I found out that even with exercising, at a certain, you still be exposed to hypertension. And so I have in the back of my thighs, there's like a varicose. You can see the blue veins because, I kind of light skin, but and like they kind of like protrude and they look kind of big. I noticed some, but it was like, and then I know as you get older, they say don't get out. Well, how healthy are you? I was venous problems. So it kind of frightened me. Like I was like, I smoked weed up until like in the 50s. But what I mean is, I noticed you didn't mention marijuana, but I guess smoking in general. And so I try to stretch to keep the veins flexible. But eventually, I guess aging. As you age, the blood vessels and arteries naturally vasoconstrict. I just wanted to know that because
well, as we talked about, age is a big risk factor for developing things like prostate cancer, but also peripheral arterial disease, and also is being associated with the venous problems which you are experiencing. And we know, especially depending on what you were doing, and if you have a strong family history, you have increased risk of these veins becoming larger because the valves are failing. You have increased pressure in the legs. And
I'm not telling you what, but you're trying to but when I run the steps, I run the bridge, I don't feel any side effects, but I want to make this joke to you guys. Opposed to us too, we do stand on our legs long. I sit, but I try to don't sit and so too long. So I get up and I be on my legs, but what I notice in Doc is when I get up in the mornings, my legs, the calf is much smaller than versus when I move around all day. So it's kind of worrisome for me. And I know I hear you talking about thrombolytics. So then is there any way to diagnose if I have microclots, etc.? Because sometimes I feel like little pins in my hand and the legs, like no reason. I see like one of the veins in the calf is kind of a little bulky, it's kind of frightening. So is there a test where you can test the input and output of the heart, etc.? Because I think my brother might have a condition like that. I have a cousin who's a heart surgeon. I think he had mentioned it one time. It's almost like a glomerulus filtrate rate or whatever. Is there any way to really diagnose?
Well, I'll speak specifically to the legs. I'll let Dr. Pinto touch on the other part. But to diagnose objectively, to really know if you have this venous insufficiency or reflux, we recommend a venous duplex ultrasound.
Which is minimally invasive and painless and involves no radiation.
No radiation.
Dr. Pinto doesn't know where to find
you.
It's
done at the bedside. And they can see where the veins are refluxing. They can diagnose the varicose veins. They can also pick up clots and other problems. Other narrows of the blood vessels that may be really important in causing your symptoms and making them worse.
I have one final question, Doc, that I think may benefit anyone. Which side, they say the best side to sleep on is the right side. And then they also talk about kinking the head muscles, restricting blood flow with the pillows and all these things. Could you comment on these little simple things that we could avoid to affect blood pressure, especially at night when most people do catch heart attacks, et cetera, et cetera. And there's a controversy as to when to take the blood pressure medication in the morning or the night. I don't know. I don't think it makes a difference. But I'll just hang up and listen because I'll just hang up and listen. Give thanks,
I think that sounds like Dr. Francis's expertise, but he's pointing to Dr. Lucas. As far as my understanding is, it really doesn't matter. Right side or left side or the attitude of your neck or your head.
What's important is that you get good sleep. You get good sleep, right? Yeah. So if you're more comfortable on your left, then sleep on the left.
So let's talk, as time is going very quickly, another major issue in our country with multiple comorbidities, including obesity and sedentary lifestyle, and that's deep vein thrombosis. Talk to us, Dr. Lucas, about the plague in our society and what exactly is deep vein thrombosis, or people know it as DVT.
Okay. So this is far too common in our population, life-threatening condition where patients develop these clots or thrombosis, usually in the blood vessels or the veins in the calves, but can occur anywhere. But that's the most common where in the lower limb, in the legs. And some of the risk factors are if you are, obese, if you're lying down for long periods of time, maybe you're post-surgery, maybe you had a concurrent illness, that is you had a severe infection, a pneumonia, a severe flu, and you were out for a while. Some association with long flight travels, especially in high-risk populations. But if you have this acute, painful, swollen limb, that is a warning sign that you may have a DVT. Very rarely there may be DVTs even in the upper limb, where one limb, the drainage from it is impaired because of a clot, usually around the shoulder area and the clavicle. So if you're experiencing one limb just being painful and swollen, don't ignore it. Don't think is just from the bad exercise I had yesterday. No, you may have a DVT, and that clot can break off and go to the lung and cause a significant problem, even death.
It can be life-threatening, and you can get a thrombosis or clot from any vein, including in urology, obviously, renal vein thrombosis.
Absolutely.
And then we minimally invasively will refer it to a vascular surgeon and do a thrombectomy. What is a thrombectomy?
So thrombectomy is where we remove the clot, and this can be done through an open surgical technique where we do a big cautomy, find the vein, and we scoop out the clot. Now we have minimally invasive techniques that we can actually suck out the clot with our penumbra machine or mechanically remove it as well. So there are a number of options into removing or getting rid of these DVTs and these clots in consultation with your medical physician or your vascular surgeon who may put you on some blood thinners. Every case is different, but now we have so much and so many tools in our armamentarium to fight it. I think we're winning the battle, but early detection is very, very important.
Yeah, so 100 years ago, one of the most common causes of death in hospitals where patients were laying sedentary for days and weeks on end would be a pulmonary embolism. What is the role?
It still happens nowadays.
It still happens. What is the role for a greenfield filter? What is a greenfield filter?
So we have these IVC filters, and for the population, this is a tiny device, and again, it's been around for a while. And
IVC stands for?
Inferior vena cava. This is a big
is?
blood vessel returning blood back to the heart. And so this tiny device is lodged into this blood vessel to prevent these clots from breaking off and going to the lungs, causing a massive problem, even death. So we usually do it in our what we call polytrauma patients, people who are severely injured, who may have been involved in an accident, sometimes in patients who have to undergo major orthopedic surgery. And in patients who have an existing clot, we may, especially if it extends up into the groin veins, those are another set of patients that we may decide to put a filter in.
Yeah, so a lot of trauma patients, some of them may not die from the trauma or even if they have a fracture of the femur, but they can die from a fat embolism, and that's a tragedy as well. Talk to us a little bit about, we are a country overwhelmed by cancer, and because of cancer, particularly advanced cancer, you can have what we call a hypercoagulable state, where you're at risk of developing deep vein thrombosis. What is the physiology behind that? Why do persons with cancer have a greater risk of developing deep vein thrombosis and in turn possibly end up with pulmonary embolism?
Okay, so there are multiple mechanisms for this, but I'll touch on two. Just from the vascular surgery point of view, one, you can have direct compression from the cancer, and we see that a lot. What that means is that the cancer is basically pressing on a major vein and not allowing the blood to flow through it. And this, what we call stasis, this stagnant blood that's not flowing anywhere, then forms a clot, okay? So we see it in patients who have pelvic tumors or gynae patients who may have cervical cancer, uterine cancer, or just large, even our women who have large fibroids, it compressing. There's a special condition that we see, and Dr. Farquharson is doing a lot of research and work in that area, looking at something called May-Turner syndrome. This is a congenital anomaly where the artery rests on the vein and compresses it, and then that person is going to pick up or going to develop left leg DVTs, so clots in the left leg. That's something called May-Turner syndrome. The other way, besides compressing the vein, is we know that the cancers can elaborate certain chemicals that mimic parts or activates part of your coagulation cascade, basically meaning that it puts you in a prothrombotic state where you're going to form clots readily. And Dr. Francis, who's the surgical oncologist, can talk a little bit about that and his experience. Do you see a lot of these patients, and how do you manage them?
No, well, I mean, having cancer in and of itself puts you at risk. It's just the microcirculation is affected, right? And so one of the things, especially when we do surgery, we encourage early ambulation. I mean, that's the simplest thing. You get surgery, you need to be up out of the bed. So it's something that I really emphasize. Get up and out of the bed because you have to move.
Yeah.
And that movement improves that circulation. And then there are other things like compression, sequential compression devices that help move the circulation, help move blood flow in your legs.
And we use that even during surgery.
And we use it during surgery too, because the person is laying on the operating table for a long period of time. And the third thing we do is chemical prophylaxis, we call it, where we use a blood thinner, and that we give them, post-op. Sometimes you even given pre-op, and you have to balance the risk of bleeding versus the risk of clotting. Clotting, actually, bleeding we can control. Clotting, especially if you get a pulmonary embolism, can actually cause the demise of your patient outside of the surgery itself. And so we pay particular attention to that. And sometimes we even have to send people on these chemical prophylaxis for a prolonged period of time, because a lot of people after surgery, especially major open surgery, tend to be more sedentary. They don't move around as much. And hence why minimally invasive surgery is so much more important, because it encourages early ambulation. You have less pain, so you tend to move around more. And so these are the things, not only in cancer surgery makes it more at risk. Patients with cancer make you more at risk. But any particular surgery, it becomes a problem.
And being obese also puts you at greater risk as well.
It does. Obesity is sort of a chronic, it's a chronic disease.
And then even
as
a cancer surgeon, it's well known that if you're obese, you're not going to do as well.
It makes things a little more difficult, but what determines the outcome in cancer really is what we call the biology of the cancer itself. Obesity in and of itself makes treatment options difficult sometimes, but what caused people's demise is more the cancer itself, because each cancer has its own particular behavior. And once we know that, we're able to manipulate that, and that's how we try to improve people's outcomes.
And obesity, and for many cancers, can make it a more aggressive form. For example, obesity won't cause prostate cancer, but many studies that are long-term have shown that obese persons can have a more aggressive form of prostate cancer. My apologies, we had a call waiting for a long time. Good evening, this is Urologist Speaks.
Hey, good night, how you doing?
Very well, thanks.
Yeah, Dr. Pinto, how you doing?
I'm great, thanks, Sam.
And your guest,
Dr. Lucas, Dr. Francis.
I wanted to ask you, because I remember you did an operation on me before, but what happened is, it's like in the nighttime, I don't have to drink nothing. I could eat food right now, eat a lot of food, and I still get up every so much in the nighttime, just go into the bathroom peeing. That's what I didn't even drink a glass of water.
And how old are you, sir?
47.
47. Well, if that's the case, it can be for many reasons. It can be for incomplete bladder emptying. It can be because of diabetes. It can be because of medication. It can be because of what you're drinking, at what time you're drinking. If you're having caffeine, if you're having alcohol, any diuretic's going to make you peeing very frequently, very urgently. It may be related to infection. It might be at 47 related to an enlarged prostate. It can be related to a urethral stricture. As you get older in middle age, there's a natural hormone produced by the kidneys called vasopressin that becomes less and less supply. So older persons, middle-aged persons are going to be producing more urine during the night. And when they were 20, they would never wake up in the night. And all of a sudden, they're waking up 2 or 3 times because of a lack of vasopressin. If that's the case, we can even give you a synthetic analog of that called desmopressin. So there are 25 different reasons. You might even have 2 or 3 of them that can cause you to pee multiple times in the night, but never accept urinating and waking up more than once, twice at most, because it's going to disrupt your sleep. Even for your cardiovascular health, you need to get 7 hours sleep. So seek help and let's figure out why that's happening, and we can come to a solution very quickly. So no matter what age, and we always say this in this radio, and I always say it personally, professionally, never let the bladder control your life. Never have a sleepless night. Never worry about drinking past 6 o'clock in the evening, which is ridiculous. Never drive with a container to urinate into. Never accept the indignity of having a bucket over the side of the bed because you have to wake up 10 times to urinate. Never avoid drinking liquids when you're out of your house because you know that you're going to have to run and pee. So there's so many reasons for it for men, women, and children. Never accept bedwetting. As urologists, we can always solve that, and it's one of the most horrible ordeals a child can go through is when they're wetting their bed. So please seek help, and we'll find a solution for you.
All right, then. Thanks a lot.
All right, no problem. So when we're talking about vascular surgery, we want to be preventative, obviously, and that has to do with lifestyle changes. That means screening is very important. Dr. Francis and I are always talking about the need for an MRI machine in the public system. Obviously, MR angiography is very important. Please help us talk to those stakeholders out there and say that we need an MRI machine for the public health system.
Absolutely.
Just from being a vascular surgeon.
From a vascular surgery point of view, we need it for patients who have strokes from coronary artery disease, carotid artery disease, and in those complex cases where we want to intervene. For those patients who have kidney disease, and this exists in like 25% of our patients with PAD, so we can't give them a contrast CT scan. We need that MRI to protect their kidneys, but also get good visualization of the arteries and sometimes veins. So MRI for vascular surgeon is very important, and I hope we get it in the public system for sure.
Well, we've imparted a lot of information, but this has to be part one of a series for vascular, because as they say, stroke, heart attack is one of the number one killers in this society and in every society. So we were speaking here with Dr. Charles Lucas, who's a general surgeon and vascular surgeon. Again, Dr. Charles Lucas, where can we find you? How can patients reach out to you if they have any of these problems that we discussed?
Okay, so you can see me at Bahamas Surgical Associate Center, 603-1814.
And where is that located?
On Collins Avenue. We also have the Bahamas Vein Clinic. You can contact me at 552-2352.
And you are in the public system,
and I'm in the
Margaret
public at the Princess Margaret Hospital and also at Doctors Hospital. So reach out anytime. Vascular disease is so important. We need to stamp it out in this country.
Any last words, Dr. Francis?
Oh, I'm happy to be here. And, Lucas is a homegrown surgeon, went off and did vascular surgery, and just want to let the public know that you have competent specialists within the country.
So, good evening and have a safe week, Bahamas. We'll be back next week with another interesting medical topic. Good night.
Put that in your pencil, make you feel like a champion.